It's Coronavirus and You, live from Litovia TV studios here at Prism Africa TV station at Go St. I'm Frederick Chitangala as usual. Let me begin with an update of where we are in terms of numbers. As a country, as of yesterday, we have 14,491 confirmed cases, and we are lucky to have 13,643 recoveries. Unfortunately, 332 people have lost their lives, and this leaves us with 516 active cases. In terms of putting meaning to these numbers, it means that our death rates or case fatality rate is just about 2.2%, which is way less than the global case fatality rate of 3%. And our recoveries are at 94.1%, which is way better than the world global recoveries, which is at 73.8%. Okay? So far, the country, as of yesterday, has done 446,329 tests, giving us test per 1 million population of 7,910. So today, we have an epidemiological discussion. We want to discuss the epidemiological implications or meaning of what we have been told in the past 2 weeks. The president did announce that schools can open, bars, nightclubs can also open. We just want to go into the details of what is expected of you as members of the community, as well as the meaning of this and where we are going from now. Let me define epidemiology as I get to introduce my guest today. Epidemiology is the study and analysis of the distribution, okay, of the who, when, and where, patterns and determinants of health and disease conditions in defined populations. It is a cornerstone of public health and obviously shapes policy decisions and evidence-based practice by identifying risk factors for disease and targets for preventive health care. To help me with this discussion, I have, once again, for the second time, Mr. Chanda Chiluba, a researcher and lecturer of epidemiology, research methods, and biostatistics at the University of Zambia RIDGEWAY campus. Mr. Chiluba, welcome.
Thank you so much, and thank you for the opportunity once again to feature on this important program.
We are honored to have you. I'm like, when I want to do epidemiology, I'll have you as my supervisor. Yeah, be reminded that we are live on YouTube as well as Facebook, hopefully. But in case you want to find this link, go to YouTube and search for Prism Africa TV. You're going to find this live broadcast right here, right now. Or search for my name on Facebook. You probably are going to catch the same broadcast. Follow with us and call in on the number you're seeing on the screen, or even a text. We want to hear your thoughts about the country's decision to open bars, nightclubs, and schools, and now churches have increased time allocated to them for their services. What do you think? What are the implications of this? Are you ready as an individual to comply to the expected public health guidelines? Mr. Chiluba, let's start with the fact that I've just mentioned that our tests per 1 million population right now is 7,910. We have only done 146,329 tests as a country of 18.4 million people. Why is testing important in disease control?
Very good question. Maybe perhaps let me start from I think last time when I featured on this program, we tried to look at a bit of a few dynamics.
Yes.
And I think one of the disclaimer in those dynamics that we looked at was the idea that pandemics change, the pattern change because we keep on learning from data. Mm-hmm. Then I think you've rightly defined what epidemiology is. There are two elements. There is disease frequency as an element of epidemiology, and there is also disease distribution. So also in terms of measurements, those are the two measures that exist within the realm of epidemiology. So you have a measure of disease frequency, and you also have a measure of association. So what we are merely doing actually is we are actually dealing with a measure of disease frequency, and that is very key to understand, especially if you want to describe the population dynamics. Yeah. Perhaps you would want to define the population dynamics in terms of which age groups are more affected, and that is key for decision making. Because you'd want to make a decision in terms of from where you started from, you had instituted lockdowns and other public health measures. So later on, you would want to see what is happening with the distribution of a disease so that you can be able to see whether you need to loosen up on the decision that you made earlier on. And that is very key for making decisions within the pandemic. But it's also key for other things. For example, it's key for things that you're anticipating, like you're anticipating vaccines, things that you're anticipating, like you're anticipating herd immunity, and so on and so forth. Yeah. But also it's key to keep on measuring so that you know whether you are underestimating the burden of a disease within the specified population, like you've rightly actually defined what epidemiology is.
Yes. Okay, so dear viewers, please keep in mind that description of what testing is, because it will be very important for us to understand how come these decisions were made by the government and where we're going, because that is a very, very important background we need to establish. Now, let's get to another related word, which is screening. What is screening? From what you have explained, we understand clearly what testing is, and in most cases, we are going for individuals that probably are presenting with symptoms or that have been exposed. But how can we define screening? We're trying to establish an understanding, because the next few questions or the next points of discussions will be based around those.
Okay, so ideally, when you're talking about screening, you're talking about targeting the asymptomatic population. And when you're talking about testing, you're actually talking about testing the symptomatic population. It's the same concept, like if one goes to the hospital, they are screened even for, when you go to the hospital, you usually present with, you have pain, you have a particular symptom, and in the hospital, they begin to screen you so that they can establish the diagnosis. So usually you would want to start with screening before you narrow it down to what specific tests you need to do to establish what a particular individual has.
Yeah, wonderful. So if I keep those questions and comments coming, I'm saying something very interesting on Facebook right now, but we also want to hear from you. I'm going to read you those comments on Facebook, but I also want to hear from you, and so you can make those phone calls, you can text us, and the number is right on your screen. Very interesting number. That's not a number that you can actually miss out. Okay. Now, we have done 146,329 tests, okay? And we don't have a huge tests per 1 million population, which is not very good. Should we now shift, having defined those two terms, should we now shift from facility-based testing among symptomatic patients or among the exposed and move to community-based screening? Do we even have resources for that?
First and foremost, I don't think we have the resources to begin to address the community spread of a disease. And that is going to be very difficult to do, looking at how we've struggled, where we are coming from. But also it's very important to understand that at this stage, actually, in most settings, in most countries, community spread of a disease is what is actually happening. And I think it will be very important to go that particular direction. But one key thing actually to address in this instance is not necessarily, I think we need to shift the focus to other forms of measures, like maybe measuring the biomarkers of people that were asymptomatic, and we begin to see what we need to do or understand the dynamics of a disease. I think I should have mentioned from the start point that if you look at the pandemic, it has a lot of different elements. There is the ethical element, for example. There is also what we call the stochastic element of a pandemic, which simply means that outbreaks will actually occur, but they will be very difficult to predict. And I think this is very key to understand. So you discover that different parts of the world, different countries, did start on certain decisions, did embark on whatever decision that they would have come up with to address the pandemic, but later on you begin to see a shift. And I think that is very key in the science, and I think if you have a disease of the nature of COVID-19, which is very difficult to predict, it becomes very imperative that you keep on learning from data, and you keep on knowing what you need to do. But all in all, I think in terms of addressing the pandemic of the nature of COVID, there are certain things that one needs to employ. Certain concepts are actually constant for all pandemics. So at this stage, I think, like I have said, there's a different type of approach that we need to employ in order to address this issue.
Absolutely. And I know during the end of the program, we will address the question, what can you, as a member of a community, do to ensure that we don't encourage the spread or community-based spread from those who are infected to those who are not infected. Now, the Zambia Public Health Institute, ZNPHI, conducted a seroprevalence survey for COVID-19 between the 2nd and the 30th of July in 2020 this year in 6 districts which had higher numbers of COVID-19 cases, and these are Lusaka, Livingstone, Kitwe, Ndola, and of course, Nakonde and Sorwezi. Let's begin with a simple question. What is a seroprevalence survey?
So the seroprevalence study actually falls within the realm of epidemiology we call seroepidemiology. And seroepidemiology is all about measuring the prevalence of biomarkers for infection, but also you would also want to measure the effectiveness of a vaccine.
Okay.
So
an intervention.
Yes. So at the stage where we've actually reached, seroprevalence studies are going to be very key in terms of a decision making. Seroprevalence study, I think, let me just rewind a bit so that I can build a subject on this. When we started last time, when I featured on the program, I talked about the R0, which we simply call the reproductive ratio, and in the layman's language simply means the spreadability of a disease. And I think
the number of infections that one case can...
Exactly. So the number of people the person who is infected can infect.
That's
so
right.
We established when I was on this program that a person who has an infection, the likelihood of infecting, the number of people that they can infect actually is 2 to 3. That was the...
Is that on condition that nothing is done to stop, to mitigate the spread?
Yes, so this is just generic. Okay. If we don't do anything, this is the condition actually. Yes, you are right. So that's what we established. But later on, I think with studies being done, it has emerged that actually...
Let me take a caller. Thank you so much for calling Coronavirus and UTV program. Today we are discussing the epidemiological implications of the decisions that were made a few weeks ago by the government. May we know your name and where you are calling from?
The audio is too bad.
We can hear you clearly, sir.
I cannot.
Could you? Yes, that's fine. Just call. If we answer, proceed with your contribution or question to our discussion today. Sorry for cutting you. You are in the midst of talking about...
Yes, so I was just trying to explain so that maybe when we get to define what a seroprevalence is and why we need to do that, we perhaps understand 1 or 2 things. So when we started with a disease, we established that the R0 for this disease is between 2 and 3. So now, and with a serial interval of, I think, 5 to 7 days. And I think the serial interval for COVID-19 actually is the R naught is quite high compared to other diseases like influenza, maize, and SARS-1. It's quite high, but what makes it actually favorable is that it has a serial interval which is wide, and that actually is key to understand.
Yes.
But later on, there are studies that have been done with respect to understanding the R naught of a disease, and some studies have reported the R naught of even between.
Let's just try to get one more time. Can you hear?
Good morning.
Good morning. Are you able to hear us now? Can you hear us?
Okay, thank you very much. If you can hear me, then that is fine.
Yes.
This is Chichi from Western Province.
Yes.
And it's good to hear that there are a lot of people following this program. It shows how popular it has gone. I would just like to give you an update on the COVID-19 situation in Western Province. Just a quick one.
Yes, please.
We have actually begun to test as Western Province for COVID-19. We started yesterday.
Wonderful.
And we tested about 130 samples, and none of them were positive for COVID.
That's good.
But my greatest concern is I don't know what criteria we are using to bring these samples in. I don't know from what setting they are coming from, because Western Province is very sparse. It's sparsely populated, very, very sparsely populated. So I think we needed guidance, like since it's now localized to Western Province, on the way that samples are coming in. Is it from high-risk areas, or are we actually getting samples from patients that do not actually have the possibility of showing positive results? Because we are interested in the positive results.
Okay.
If not, we shall just actually be wasting resources testing for COVID. Because these reagents, the machines, the tanker, cost money. The reagents cost money. So I don't know whether Mr. Bland can be able to help us with the best way that our province, our Western Province, can be able to pick out from the best sample from the population where can be sampling, where to test from. So that's my concern.
Thank you so much.
Thank you very much.
You are through to coronavirus. You are through to the program. May we know where you're calling from and your name. Please proceed with your question. You can proceed with your question. We can hear you.
Yes, I've got questions on the ongoing corona discussion by Dr. Chanda and the guest.
Where are you calling from?
Can I give it to you now, or do I go on live?
Please, we need to hear from you. You can ask us now, right now. You can go ahead and ask the question.
You are low.
You can go ahead and ask the question.
Yeah. My question is case counts. Sorry, because we're discussing coronavirus, I just want to understand, because I think the public is paranoid. This is maybe I should give it my name.
Sure.
Hello?
Yes, we can hear you.
Can I take?
Okay. We hope our technical guys can sort that out. But once you call and we pick, we can hear you loud and clear. Just proceed with your question. Even if you don't hear us, you will see us pausing the discussion because we are listening to you. Or you can text. You can text the number you are seeing on the screen. We're already receiving a few texts, and we are receiving a few comments on our Facebook live broadcast. So let's proceed, Mr. Chiluba, on what we're discussing. Yes.
So The other note that I was trying to describe is that currently there's been some new studies that are suggesting that the R naught for actually COVID-19 could be as high as 5 to 6. So in terms, so now I can come to the what the seroprevalence means. So in a seroprevalence, you actually want to know the true infection rate in a population. Remember when we started with the outbreak in March, we were testing people who were presenting with symptoms.
Yes.
But later on, we also realized that there's a very big number of people who are asymptomatic. So if you have that in a pandemic, it's very difficult to know how much of your population is actually affected. And it's also difficult to know whether you are heading towards herd immunity or not. So that's why seroprevalence will be able to establish those things. And I think that's the reason why the Zambian gave a report around that. So seroprevalence is just about knowing the true infection rate of the disease. And if you recall, when we started, we were more focused on case fatality rate, but in seroprevalence, we want to be focused on infection fatality. Infection fatality rate.
Briefly, what is prevalence?
Prevalence is simply in the layman's language, is simply the number of people who are infected with a disease, and you divide that by the entire population.
Wonderful. All right. Now, so talking about this seroprevalence study that was done by ZNAPHI between 2nd and 30th of July this year. Initial findings from the Ministry of Health seroprevalence survey indicates a 5 to 11%, average of 8% infection in the population. And let me just take this score. I think somebody's trying to call back again. Okay, but you can please text if you think going through is a problem. And then between 12 and 15% among outpatient service seekers, and this is 13.5% by average. Thank you so much for calling again. Could you proceed with your question and contribution?
Hello?
We can hear you.
Hello?
We can hear you loud and clear.
Okay. This is Christopher Kanumba.
Okay.
I'll first ask a question. For how long does it take for COVID?
Ask that
how
again.
Long does it take?
Ask that question again.
Pardon?
Could you repeat the question?
Let me call. I can't get you clear. Let me just come back.
Okay. I hope we can resolve this, my director. Otherwise, we are going to lose very, very important contribution. Let me make another attempt. Okay, so you can proceed with your question, please. Can you hear me?
Put me through to the discussion.
You are through to the discussion, please. You can proceed with your question. You are live on TV.
Put me through to Dr. Chanda.
Okay, so please, if you call, switch off the other TV because we can hear ourselves. And that's perhaps the reason you are not able to hear us. But if you call that number on the screen and we have answered, proceed with your question. We will hear you. Okay, so I think somebody is calling my personal number. Let me see if I can get this. Hello, you're through to the TV program. May we know your name and where you're calling from?
This is Reverend Christopher.
Okay, Reverend, I'm the only one who can hear you for now because of challenges on the other line. Could you proceed with your contribution?
Yeah, my question is, people are paranoid. So
Yeah.
The question which is being asked is case counts and mortality estimates. Are they correct?
Okay.
And then the other question is, are we tracking the right health system indicators?
Okay.
Yes, sir.
Thank you so much, my guest, to attempt to answer those questions. Thank you.
Yes, yeah, but I've tested it on the other number, the same question.
Sure, we appreciate.
Thank you, sir.
You're through to the program. May we know who's calling and where you're calling from?
This is Christopher.
Please proceed with your question.
Yeah, no, I can't get you clearly. But my question was first, for how long does it take for you to know the results if you are tested for COVID-19?
Okay. Is that so? All right, thank you so much. So I'm going to allow my guest to answer those questions before we proceed to my next question, and also reading some of the comments we are receiving on the social media.
Yeah, so if I've gotten the question correctly, I think there's one who is asking about which one should be the target population for us to be doing the test. I think that should be from Western Province. And I think the Reverend is
asking whether we are chasing after the right indicators in the health system.
Exactly.
And whether the numbers are correct.
Okay, so I think for the question from Western Province, I think it's the same thing that we are discussing when we are talking about seroprevalence. So at this stage of the pandemic, we have a lot of people that were asymptomatic, got infected, and we didn't know about that, and actually they recovered from the disease. This is the whole idea of a seroprevalence, is to be able to measure the responses in terms of the antibodies. So the word seroprevalence, actually what we are doing is we are doing a serological test of antibodies against SARS coronavirus 2. So that's exactly what we are doing, and I think in terms of, so at this particular stage, we don't actually, we need to do studies of a seroprevalence nature so that we can be able to measure everyone, those who were actually asymptomatic, so everyone in the population, those who were asymptomatic and those who presented with symptoms. And it's very key to try to compare the two groups, the asymptomatic group and the symptomatic group, so that you can be able to, because you can actually develop antibodies to a disease, but it's another question whether the antibodies actually persist for quite some time. It's also important to know whether the antibodies are actually enough. You have actually produced enough antibodies against the virus.
Let me take this. Thank you so much for calling to coronavirus, and you. Can we know your question and where you are calling from? Your name as well? Okay, please switch off the TV once you get through to the line. Obviously, you are not going to be able to hear yourself on TV, but you can watch this once we are done. Okay. In the meantime, let me take that again. Hello? Yeah, through to the program. Okay, we continue hearing ourselves on your phone. Please switch off the other side so that you can hear us and we can hear you properly. But otherwise, you're calling again. Please switch off the TV on the other side.
Switch off the other side so that you can hear us and hear properly. You're calling again. Please switch off the TV on the other side.
Hello? Okay, so it means you can hear me telling you to switch off and you're not switching it off. All right. Let's proceed with our...
Okay, so then the other question from the Reverend is about whether we are actually targeting the right measures in terms of the case fatality rate. In any given pandemic, and the concept is that when you have an outbreak, you want to quickly be able to actually isolate the cases, identify them and treat them, and be able to know the case fatality from your cases. So that is the standard.
Okay, let me attempt another call. You're through to coronavirus, and you, may we know your name and where you're calling from?
I hope you can hear me. This is Anderson. I'm calling from Lusaka.
Okay.
So I've just been thinking about one particular aspect that I don't know if it's been taken into account, but it might probably help with regards to decision making. I don't know the current state of affairs when it comes to modeling, just to give us an impression of what we'll begin to see in the next few weeks or months, or probably next year. I don't know what role that will play as well in us coming up with better decisions, especially with regards to how opening up schools and bars and the effect this will ultimately have on the rates of COVID-19.
All right.
Yeah, thank you.
Thank you so much. Much appreciated. Okay, so
yeah.
on the Reverend, did we finish?
Yes. So on the Reverend's question, I think the measures are the correct measures. You want to know the case fatality rate so that you can be able to do your lockdowns, make decisions on other public health measures. And then later on, the way you measure actually shifts and you begin to do seroprevalence. You want to measure the infection case fatality rate and so on. For the question
from
that...
Christopher Kalumba was asking about whether the numbers we are receiving are correct. Oh, sorry. How long it takes for the results to come out. Let me pick another call. Hopefully I can be heard. You're through to the program. Tell us your name and where you're calling from. Good morning.
Hello.
Good morning. You're through to the program.
Hello, good afternoon.
You're through to the program. Please proceed with your contribution.
Am I through to the show?
Yes.
Good afternoon.
Good afternoon.
Yes, I can't speak. This is
Okay, all right.
Yes. Good afternoon.
Good afternoon.
Hello.
We can hear you. Just proceed with your contribution.
I just wanted to make a contribution.
Okay.
Yes. Can I go ahead?
Yes, please.
Yes. Okay. Thank you very much. As we are aware, COVID-19 stabilizing the nations, and Zambia, the country has now opened up, just as many other economies are opening up. And I think what we should expect as this disease is going on is that we should expect a spike in the number of coronavirus cases going up. Because of the children going to school, because of colleges opening, we should actually expect the numbers to go up. But another dimension that I wanted to bring to the program is the immunity. Economies are being opened on the basis that people are achieving immunity, and we have heard that there is a number of people have been exposed to the virus, and I think that number should be quite high.
Yeah.
So, to give an example, I'm sure you all heard of the Swedish experiment.
Yes.
The Swedish experiment where they never really looked at the economy. They just let the economy run on its own, and as a result, a lot of people got infected. So now in Sweden they are talking about what is called herd immunity. That a good number of people are exposed to the virus. As a result, they have achieved some levels of immunity. I'm sure my colleague on the panel will agree with me that to achieve a good herd immunity, at least 60 to 70% of the population must be exposed to the virus, which in Zambia might not be the case because people in the rural areas don't move as much as people in the urban areas. In the town, I expect that there could be some form of herd immunity in the towns like Lusaka because we never really shut down anyway. But in the rural areas where the population is sparse and people don't mingle as much as we do here in the towns, like on the Copperbelt, Lusaka, so here there might be some form of immunity.
Okay.
That's what I wanted to say about it. But the Swedish example is a very good example of a country achieving herd immunity. But in Zambia, we are nowhere, I think, near total herd immunity.
Thank you
very much.
Much appreciated. Okay, maybe you can pick it up. I saw you shaking your head.
Yes, I like the question, and actually the question is around seroprevalence. So that's the reason why we actually do seroprevalence, to be able to establish whether a certain population has actually achieved herd immunity. Mm-hmm. Now, you understand that you can't say that for us to reach herd immunity, we should have at least 60% of the population's the population who are infected with the virus. That is not true. That number is not a constant. So, for example, I was talking about the R naught of 2 to 3. Now, let me give you a formula for herd immunity. So, herd immunity actually is equal to 1 minus the inverse of 1. So simply meaning 1 minus 1 over R naught. Mm-hmm. So if you have, let's take the worst case scenario. Let's take, maybe you are likely to infect 2 people. So let's put 2 in the formula. The answer there will be actually the herd immunity that needs to be achieved is actually 50%. Let's put 3 there. If you put 3 in the formula, the herd immunity that is supposed to be achieved is about 67%. Now, I talked about a study that was actually a recent study which says actually that the R naught for COVID-19 could actually be 5 or
so higher
5 to 6 higher than 3. That is what the studies have established. So that simply means that if you are slotting a 5 in the formula, you're going to have 5 and 6 into that formula, your herd immunity figure would be 80-something percent. Mm-hmm. So we are not sure. So that's one. So issues to do with herd immunity, we are not sure because we keep on having new R naught and new dynamics about the disease. So it's not true that you would say the herd immunity that should be achieved is actually this much until you have established the true R naught for the disease. Now, let me quickly go to the Swedish approach. Yeah. Actually, if we've actually followed the minister from Sweden, also the expert in charge, I think, should be Tegnell. They've actually refused that actually their intention was not to reach herd immunity. That's not true. Then the other thing is, I think different parts of the world have actually said Sweden did not have a lockdown, they did not have what. They actually add these things to some extent. You have to understand the Swedish culture before you say they didn't lock down. Because what they did actually is understanding their culture, and their culture is that whenever the government gives prescriptions about things, people are able to follow instructions. So what Sweden did was to understand their culture. And in their culture, there is that advantage. So they didn't lock down, but they gave prescription of what people needed to do. And they said people needed to avoid crowded places. People needed to stay at home. And actually, if you go, if you checked around that period, and actually there were videos circulating, you will see that actually there was a lockdown, except that it was self-regulated. Mm.
All right. Let me first, before we go to what I wanted to ask you, just read a few comments from both text messages and comments on our live broadcast on Facebook. For those that managed to call in, thank you so much, and I apologize for the bad sound feedback you're getting. Hopefully next time we're going to be able to improve. Victoria says, as an individual, I follow the health guidelines, meaning as an individual and also as an adult. I follow health guidelines, but how sure is the government that our children, especially those in boarding, will be safe and follow the health guidelines? And then we have, okay, she writes back again. With given health guidelines, we have seen COVID-19 spread increasing. Is there anything else we can do both at community and individual level? Maybe that you can take it. Okay, so let me also, if you're just appreciating the program, but let me also take some of the text messages coming in. This is Petula Chisompa from Lusaka. She says, with the opening of bars, schools, churches back to normal hours, How prepared are we as a nation? Won't we have cases doubling, especially from schools with children under the age of 8 being more vulnerable to the disease? Similar to what Victoria was asking, let's look at the next question. Good afternoon. What can be the explanation behind the fact that African countries seem not to be as affected as the other continents in terms of mortality rates? No name on there, but thank you for that message. And the next one comes from, I think this person managed to call in. I have a question on the coronavirus discussing going on, whether the public is paranoid about this. Are case accounts and mortality estimates correct? And are we tracking the right health system indicators? This is the Reverend. I think we did attempt to answer that particular question. Yeah, so thank you for everyone that managed to go through. And also, despite that, we had bad audio, but we're going to improve on it. Trust me, okay?
So maybe let me try to answer some of the questions. And yes. I think most of the questions that are being asked, they can be lumped up together in my next response. But I think there was a question which is similar to the comment about the Swedish not having instituted a lockdown. And I think that question came from Anderson, who is asking about whether we can use some modeling science to be able to make decisions and ascertain whether the children are safe in school or not. I want to, I think, put a disclaimer that you need to be very careful when you talk about modeling. And I think it's the reason why when we started this program, I talked about the stochastic element of COVID-19, and that is that outbreaks will actually happen, but they'll be very difficult to predict. There is one of the predictions that was used previously is the Imperial College of London a model, which actually for Sweden it predicted that there were going to be 100,000 cases by end of August, and for the USA it predicted that there were going to be 2.2 million cases in the USA. But if you look at what actually transpired, Sweden only had about 5,000 cases in their population without instituting the lockdown. So modeling for a disease that has a lot of uncertainties, for a disease that you are still learning about, is actually quite difficult. And I think for most of the modeling science that is done, we tend to go the frequentist way. And you will see that most of the modelings that have been done are more into the frequentist-oriented than Bayesian-oriented. In the Bayesian modeling, you can be able to visit the models and be able to change your priors so that you can now use the new and emerging data to understand other dimensions. The other question, I think, on whether the kids are safe, and I think those questions center around social aspect of a disease. And I think, yes, I would agree there's been a lot of apprehension, also what I would call social...
Except when the president says bars can open, everyone was excited. There was no apprehension on that one.
Everyone was excited, yes. So there is also an issue of social cognizance, yes, and there is also an issue to do with what I would call social contagion, yes. So there is a book called Mistakes Were Made, but not by me. I don't know if you've read that book, and there's a concept in that book which is called contemporary schismogenesis, which simply means that when you have a pandemic of the nature of COVID, there's a lot of divide, there's a lot of schism. So people have a certain perception, and I think schismogenesis simply means if I take a certain position in life, I say I'm going to go left, you say you're going to take the other side just because you want to be against me. So you're talking about governance versus the citizens that are being governed.
Hello, good afternoon. Good afternoon. Please try as much as possible to reduce the volume on your other set where you're watching us from. so that we don't hear ourselves talk.
Yeah, so there is a lot of schism between the public and the governments, also a lot of schism among scientists, and I think in the sciences we don't need this. We actually need a lot of openness and civility within the scientific world. We've had situations where people have actually indicated they are not going to take a vaccine. Mm-hmm. In the USA, a study was done, and quite a huge number of people indicated they will not take the vaccine. In Africa, we've already indicated we don't want a vaccine to be tried in our continent. But if the vaccine is going to be produced elsewhere, are they going to give it to you? Because the vaccine has to be tested in different. So I think my key point here is the schism and the questions whether the kids are safe or not. And I think some of the seroprevalence study that have been done, and I think one of the most important seroprevalence is the one that was done in Spain, because it was done the right way. The sample size was quite great, and I think they used some immunoassay to test the antibodies, and they compared it with the one which is cost-effective, which is called the point-of-care test. And if you look at these seroprevalence study, actually, the prevalence for Spain was actually about 5%. Now, Spain was actually one of the most hit countries in the world, but has only produced a seroprevalence of 5%. So we are so much far away from herd immunity if you look at those figures.
So let me put it now. Ask this question, because now you have just talked about seroprevalence. Even though there is a question that you still haven't answered, are we being paranoid?
Yes, we are being paranoid in the lay world, but we are also being paranoid in the political world. We are actually being paranoid in different sectors of community, and that is it's not very good for an outbreak of this nature. Because I think most of the decisions that are being made are data-driven. What you see, and then you make a decision. Mm-hmm. But if we're going to throw a lot of questions, and I think in most of these studies, maybe I can qualify that point. In most of these studies, actually, what has been observed in the seroprevalence studies is that there is actually a low infection in the younger ones. And I think it appears that there is a correlation. As age increases, the infection rate for the disease increases. And I think for the seroprevalence for Zambia that was done, I think that's what it needed to do. What I don't know if they have not yet produced a comprehensive report.
Okay, so just there, let me pick it up. No comprehensive report is yet to be produced, but they indicated when they made the announcements of the preliminary findings that soon the report will be out. So in the initial findings of this seroprevalence survey indicates that a 5 to 11%, which is 8% average infection in the population, general population, okay? And then 12 to 15% among outpatient service seekers, that's 13.5%, and then 4 to 8% among healthcare workers, which is 6%. The survey highlighted that there was a high prevalence of COVID-19 in July and a low prevalence prior to July. The survey showed that most Zambians are susceptible to COVID-19 and that more infections are occurring in the community than being reported.
Yeah, so let me just make a strong comment on that survey. And I strongly feel that this survey is actually in terms of the methodology, I think it is methodologically extremely weak, because if you look at the samples that were gathered in this survey, it was the health workers and the outpatients. Mm-hmm. I don't know if that would be in the comprehensive report, at least from what they have produced.
Yeah, there was also another group, the general population.
The general population. Mm-hmm. What I feel they needed to do in that survey is, because when you're doing a seroprevalence, you want to inform yourselves about the lockdowns that you instituted, about the public measures that you had. In this case, if you're only going to do a seroprevalence that targets the health workers and the outpatients, it means that you'll be making a decision around that. Yeah. So I think what it failed in terms of the methodology is failing to stratify their sample in terms of sex, in terms of age, in terms of, I think the other thing is they needed to follow up on the health care workers' households. They needed to follow up on the outpatients' households, and that I think was going to give them a much bigger sample, which is random and which was going to be representative of the population.
So I'm told, or I heard from the announcement when the minister and also Professor Mulenga as well as Professor Mkonka were announcing that a bigger one is coming. big nationwide one. And I hope the results will also come out as fast as possible so that we can be informed. Let's proceed. I know time is not our best ally. On the 11th September 2020, the Republican president announced the partial reopening of bars, nightclubs, and related outlets from Fridays to Sundays with immediate effect on that day, and to operate from 18 hours to 23 hours, considering economic reasons, and also ensuring that public health guidelines were observed once these outlets are open. And he mentioned that this was a pilot, so that we see how things will move. Otherwise, he could actually close them again. I must say, this was received with jubilation by people who indulge in the golden brew. What's your comment on this? I like the fact that they will only open for 15 hours a week and 3 days only.
Okay, so let me just quote back what I earlier on said. I talked about a book called "Mistakes Were Made, but not by Me."
Yeah.
And I think one of the sub headings in that book is it talks about why we justify. Foolish beliefs, actually, and why we support bad decisions and hateful acts. And one of the elements in that book is it talks about good intentions, bad science. So if you look at the schism there is that, yeah, you open the bars, but you say it will only run from this particular point to that point. The intention is good, but then where is the science to say that we will only open up to within this specified range?
He did mention that.
Yeah.
I know that in his own ways. I wish you saw the speech. Eh?
Yes.
I know that families of people working the bars, people own bars and these outlets are suffering. Wasn't that good? A very good intention.
So that's a very, very good intention,
yeah.
And that's what actually I'm talking about. And I think if you are going to open the bars, in this case, and the other outlets, and I think opening simply means opening. There is no science in saying we'll open only up to this point. It's not like maybe if you continue opening up beyond 21 hours, if you are still open, then the infection increases. So the intention is good.
They'll be too drunk to social distance in the bar.
So I think the intention is quite good because actually for me, and I think from the onset, I've always supported the idea that we didn't lock down the economy because let me talk about two important findings in the social sciences is that wealth is good for health. The other one is that education is good for health. Mm-hmm. So you are not going to lock the economy and say we are saving lives, but then people are going to suffer. And I think if you look at a lot of studies that have been done, there is a high correlation between wealth and health. So the poorer you are, the more likely for poor health outcomes, and the better you are in terms of your wealth. And I think when we're talking about wealth, we are not talking about Bill Gates or Dangote. We're just talking about... We're just talking about meeting the basic needs. And I think the decision is very good, but I think I was expecting it will just be open. Open is open.
Yeah.
Yeah.
All right. Can I quote the president in the next question? I'm fully aware of the negative impact the closure of educational institutions has had on pupils, students, teachers, lecturers, parents, school owners, and the general public. And this is what he said about the owners of bars, as well as those who work there. Through interactions, observations, and reports, I'm disturbed by the vices that are happening at community and household levels. These include, but not limited to, the following: teenage pregnancies, child marriages, rape, defilement, alcohol abuse, incest, and the other delinquencies. These vices may not only lead to these young people dropping out of school, but may expose them to HIV and AIDS and other sexually transmitted diseases, solving a public health problem, in my words, and creating another. What's your take? But just hold on, we have a question. A phone call.
Hello?
Hello, we can loudly hear you. We want to know who you are, and you can ask the question thereafter.
Hello?
Hello, good afternoon.
Okay, so let me just quickly respond to that. And I think the president was very right to indicate that actually this disease has actually exposed a lot of those issues, issues to do with defilement and early marriage and so on and so forth. And according to actually, that one key thing about education is that according to UNICEF, 500 million children did not have access to education, do not have access to education due to COVID-19. That is a very huge number. And if you are going to go with what I said, where I'm talking about that education is actually good for health, then you understand the impacts that these pandemics can have, especially for people that instituted very stringent measures in terms of the public health measures. So we are yet actually to feel the impact of the interventions that we are instituting right now. So it's very key to understand that you cannot be saying we are saving lives and then you are killing the economy, because the two are actually the same. The intention is the same. When you want to improve the economy, you actually want to improve the livelihood and the well-being of populations. It's the same thing that you'll be doing in terms of the instituting lockdown measures and other public health measures. You are actually targeting you are targeting the same indicators in the population.
Wonderful. We are almost coming to an end of the program, but if you still want to squeeze in that call, you are welcome. And few attempts have been made, especially by the last caller, to call us, but they're not able to hear us. If you can hear me right now, call. And when I answer, even if you can't hear me, just proceed with your contribution and your question, but reduce the volume on your TV set or on the other item we are using to watch us. And then we are going to listen to you until you finish talking, then you can cut, and then we are going to answer your question. Don't worry if you can't hear us. We will be able to hear you.
So maybe as we wait for the next call, I can just make a very good point about seroprevalence test. And you've rightly said that they are going to do another one. And I think what is very clear about seroprevalence is the test. And I think in the USA, the FDA has actually been very strict on which test you have to use in your studies. And I think we need to be very stringent on that. And I think there are issues to do with sensitivity, which have not yet been understood, issues to do with specificity of the test, which have not been understood. But for the Spanish study that was done, you can tell that it was a very good study because of the specificity of the immunoassay they used was, I think, above 90%, and if you have a specificity of above 90%, it means that you are going to have a very good positive predictive value, simply meaning that the people that have been tested positive actually have a disease. And also you're going to have a very good prediction in your, you're going to reduce on your false positives, or improve actually on your sensitivity. That's when you have a very good specificity test.
That's right. My last question, as I promised the viewers, obviously, will be on what me and you can do now that everything is opened up. But before I get there, what does that mean? By average, these numbers from the seroprevalence survey that was done by the Ministry of Health, by average it means 10% of the population have, if we can generalize, have had COVID-19 and without even knowing about it. This simply means more than 1.8 million people in Zambia have had COVID-19, close to 2 million. When you factor in the R0 of between 2 and 3, what does it mean right now?
That's a very, very good question. And I think if we use, for argument's sake, if we use the R0 of 2 to 3, we are very far away from herd immunity, and I think it's not the idea one would actually tolerate at this stage, because 5% is very small. Even the Spanish study, it was 5% nationwide. Even the Santa Clara study in the USA, it was about 5%. And I think the only study that actually had a very high number was the study in India, which, and the study in India was not for the whole nation. It was in New Delhi, where the seroprevalence was about, I think, over 25%. And I think, we are so far away from herd immunity, and I think we still need to follow the guidelines at this stage. We still need to follow the guidelines, hand hygiene. We still need to, and I think you should not be surprised that at some stage, some countries will begin to go back to where we started from, instituting lockdowns. Like Israel has actually undergone another lockdown. It's the first country to undergo another lockdown after they had instituted the first one. So we shouldn't be surprised that we actually begin to go back and institute the same things that we actually were instituting, or actually institute the things that we didn't do in the first place.
Absolutely.
So the infection is, the cases are being monitored. The seroprevalence studies will provide much more depth for different countries, but also seroprevalence are also key when you are heading towards vaccines, so that you can know the epidemiology of a population before you actually administer your vaccines. The seroprevalence studies will also be very key when we actually give vaccines, because vaccines can be given, but it's another question whether a vaccine is effective. So we don't know how effective the vaccines will be. So seroprevalence studies will be done to establish whether people are producing enough antibodies against COVID-19.
We have had 2 reinfections so far, one of the few countries in the world, if not with Spain and the US only. What does that mean?
And that simply gives you an indication that you can actually, there is a possibility that you can actually have immunity, but you can actually lose it over time.
Yeah.
And I think this is actually the same thing for any other diseases. You lose immunity, except that you lose it after a much longer period of time. But for this, we need to understand that particular dynamic. Otherwise, we'll still get to the vaccine that everyone wants, but it's another question whether a vaccine will be effective. Are you going to create enough antibodies? Is another question. Are you going to have an immunity that will persist for a longer time? That is also another question.
Mr. Chiluba, thank you so much.
Thank you so much.
And to all of you that managed to call, text, or even comment on our live broadcast on Facebook and on YouTube, we said thank you. Once again, I apologize for the letdown of our technology in terms of audio, but next time, please, we promise to do this job very, very well compared to today. We'll have this week to look at what we can do to improve this. In the meantime, please, this means, our discussion, what it means that you and I have got a lot we can do. Please keep wearing that mask when you are in pub. Wash your hands as frequent as possible, as often as you touch surfaces and external bodies. And also ensure that you stay home if you don't need to go anywhere. Your health is your choice, as I always say. In the meantime, please stay safe and take care. We'll see you next week. Bye-bye.
Being pure, if any virtual or excellent, think about such things. You're watching Prism Africa.
Ejijo jilajimwe jakulikinga kuli omusongo bambangwabo corona